Hello, everyone. This is Marius Fjorgios from Basel, Switzerland, and today we're going to be talking about distal occlusions and mainly our techniques on MCA distal occlusions. If you're interested in another video about ACA or posterior occlusions, we can do that. Just write in the comments below, and then we will produce that in a couple of weeks. So the idea was to talk a little bit about distal occlusions, and let me share my screen. So then we can start discussing about that. It's going to be online in a second. So there you go. Now I made it. Okay, so let's talk DISTAL. These are my disclosures, and as you can see, we are cooperating with most of the companies that produce our catheters and stent retrievers. I didn't receive any money to do this talk. It's actually my own opinions and the opinions of my team that I'm presenting here. And I would like to start with a provocative case. And funny enough, this was the first thing that Google produced when I Googled meme and provocation. Funny that Daenerys Targaryen shows up on this, but let's start with the case. It's a 62-year-old patient arriving at midday to our hospital with an aphasia and paresis on the right side. Admission in HSS was 12, so he was a bit affected. And these are the images that we saw on this patient. On the CT, we didn't find any early signs. Didn't see any demarcation. And on CTA, of course, there is a big arrow there showing the occlusion, distal M2 occlusion. But I sometimes find it difficult in these cases to actually find the occlusion on the CTA. This has also been shown on studies. And what really helps is perfusion on this. So we call perfusion actually the MeVO detector now. If you need an automated software or no, that's a big discussion. We use it here in Basel. But what I don't really trust all the times for distal occlusions is this core estimation. Because again, those software algorithms were made for LVOs. And until we have a dedicated one for MeVOs or DVOs, then you mainly need perfusion to see that there is a deficit there, right? So the green cards are the important ones. And if you see the deficit, you go back to the CTA and you are checking your angio for occlusions. What, for example, we did on the trial, I can also show you here the single evaluation, so the normal evaluation of the perfusion with CBF, CBV, and Tmax, is that we took a mismatch from perfusion cards to native CT, or the other way around, from native CT to perfusion map. So actually, if the native CT is looking good, no demarcation, and then the perfusion shows a deficit on the Tmax cards or on the time cards, then for us in the distal trial in the late window, it's a mismatch, and then you can go on and randomize. But again, let's go back to this case. So you see some mismatch there. You see that there is a difference between CBF and CBV on the single cards. And this was a case that actually wasn't eligible for TPA, came in the late window, so couldn't also be treated with TPA. And colleagues, for whatever reasons, or I think it was an earlier case, we couldn't randomize back then. So they didn't treat the patient, they didn't randomize the patient. And this is what happens after a couple of hours. So why I'm showing this is to just show you that this can be the natural course of a distal occlusion also, right? I know a lot of people think that, yeah, when you use a catheter, you're going to produce bigger bleedings, and this is dangerous. But what I've seen in my experience is that something like this can also be the natural cause of a stroke. So again, I think it's important to do this trial. and this is why we need also more randomized data to be able to answer this question about these distal occlusions. And of course, also this patient didn't have a amyloid angiopathy. So this is a bleeding related to the occlusion that we saw earlier. Regarding the question if we have enough evidence at the moment or no, actually the answer is no. We have evidence on dominant M2s, as you can see on this slide here. But dominant M2s are M1-like M2s, and usually when we are talking about a distal occlusion, we are talking about the non-dominant M2s, the M3s, M4s, the ACA, the PCA, and stuff like that. So there is no randomized control data on those MeVOs and DVOs, and this is why we need to do the trials, and we need to include patients, and we need to randomize patients. So if you're already activated for distal, think about, you don't have to do thrombectomy to every case. It's better at the moment to do randomization on those cases. But that brings us to the distal trial. And this is a pragmatic trial. So what we do is we let the patient come in the hospital, has his imaging and examinations. And then after his best medical treatment, so he can get TPA, he can get in the late window aspirin, etc. Then we randomize for angio with thrombectomy or no angio. So this is what we randomize for. And you can see here we have planned 526 patients, 1-to-1 randomization with a standard of care. And after that, we randomize to EVT or no EVT. We plan over 40 centers in Europe and Canada. And we have patients from 0 to 24 hours in the trial. So again, I touched a little bit on the topic before. Within the first 6 hours, you don't really need perfusion or advanced imaging. It's just plain CT and a singular occlusion on CTA. If you have the late window patients from 6 to 24 hours, then it's native CT compared to perfusion. And if you have a mismatch there, then you can go on and randomize patients. So we try to be pragmatic and we try to keep this as simple as possible. You can see the countries up there that are planned for the trial. But again, we're also happy for other countries that have interest. And at the moment, it's Switzerland that's activated a lot of centers in Germany, in Spain, in Belgium, in Finland, and we are now activating centers in Portugal, in Israel, and UK and Italy are going to be the next countries. The design is, as I told you before, pragmatic. So we let the patient come into the hospital, we do the examination, CT, standard of care treatment, and then we randomize the patients to EVT or no EVT. And the primary endpoint is going to be MRS after 90 days. And as you can see, the inclusion criteria are also pretty pragmatic. So we want an isolated MeVO or DVO, and then we want NIHSS of 4 or more, or symptoms clearly disabling to this particular patient. This is the status at the moment. So we have 25 sites that are initiated among the countries that you can see. And until the end of the year, we will be having 35 sites activated. Regarding the patient count, you can see that this was the status at the end of November, 60 patients, and now we have beginning of December. And actually today we had patient number 73 in Charleroi in Belgium. So we're really happy about that. And thank you to all the sites and hospitals that are supporting us, all the PIs and their teams. But then again, we have to be pragmatic. We have to go up to 526. So again, if you are activated and part of the trial, think that you can also randomize patients, not only do thrombectomy on them or not treat them. Of course, there's also an option. And on the other side, if you have interest in our trial, just feel free to text me, send me an email, and we will be talking about this. Okay, so let's start after this intro now a little bit and talk about our techniques. So this was a 40-year-old patient, late window, lasting well, day before at 11 o'clock, wakes up at 8 o'clock with speech difficulty and paralysis on the right arm. NHSS was 9, and these are the images. You can see on native CT there is no early signs, there are no early signs, no demarcation. And on CDA, you can see that, or you have to trust me, I'll show you videos in the next slide, but there is an occlusion there. On the left side, again, our MeVO detector perfusion shows that there is a deficit. That's what we care about. Again, I don't really check on the milliliters here for the core because I don't think this is very accurate. And as you can see also on the single cards, there is demarcated, if you want, in fact, on CBV, but there is also a mismatch, and especially if you check the upper parts of the brain on the central, post-central region, you can see that there is some mismatch between CBV and CBF. But then again, this is late window. We have some M2 occlusion. We have an M2 occlusion there. And what would you do? Would you randomize? Of course, you would randomize. But this is a typical case that I find is really interesting. And this is something that I would love to have in the trial. Cases like that. On DSA, when you go to the angio, you actually are not so easily able to see the occlusion on the P view. If you do the runs from the carotid, this is why on the next slide you will see a run from the M1, and this is really helpful. So you can actually go to the M1, do a run from there, and be able to see the occlusion. This makes life easier. Or as other people do, even do a 3D angiogram then from the M1. And those lateral angiograms are really important because then you can actually see the deficit there. You can see it's a non-dominant deficit, and then you can go on and treat the patient. And after recanalization, you can also have the comparison and see if this is a better reperfusion result. This is the image that I was talking to you about from the M1. So this is a big aspiration catheter put in the M1. And as you can see now, you can more easily see this M2 occlusion, mid M2 occlusion of this non-dominant branch. And I also find it nice to see here that, you know, this ventral part of the MCA territory is not being shown because it's provided by the anterior temporal artery, obviously, that on the last slide you can see is coming out from the mid M1 segment, right? So this is a small variation of the segments, but again, nicely seen here, the occlusion in the M2 branch. So what would you do now? The next step for us is to go and navigate distally to the clot with a small microcatheter, and then place a smaller 3 millimeter stent retriever on the segment. And one thing that we will be discussing also for inferior occlusion, as you can see here, is that we place this stent retriever primarily distally to the clot. So if you're if you know our safe technique about LVOs, you will probably think that it's similar to the safe technique. This is right. And if you are not acquainted with our safe technique, please click on the description below, and then you can see a detailed video of you know, how we treat those large vessel occlusions. As you can see here, we have placed a small stent retriever primarily distally to the clot. This is where my microcatheter now is. Again, this is a small 6 French, 7 French aspiration catheter. And what we will do now is that we will exchange this microcatheter for a smaller aspiration catheter, a 3 French aspiration catheter. And I'm usually in this talk, as you will see, are not talking material specifics, because if there are multiple microcatheters, you can use multiple. One thing that I found is that the headway duo, the long headway duo, is really helpful for M3 occlusions. For an M2 occlusion, you can take any soft O17 microcatheter, like, I don't know, DVO, Pro 14, smaller ones, the Headway 17, or the rebar catheters. So again, from my point of view, you can take any soft O17 microcatheter and put it in the M3, or you can take the longer one that I was telling you about, the Headway Duo 167. If you do that, the advantage is that you can then work quadriaxially with a 3 French aspiration catheter. And again, I'm talking now specifics. The 3 Max, the 153, is available in Europe. And then you can work quadriaxial with a long sheet, a 7 French aspiration catheter, which is usually 130, then the 150, 3 French aspiration catheter, and then the long microcatheter. So then you will be working quadriaxially. Again, then if you're working like this, you can start, with 4 materials from the beginning. If not, then you can do the blind mini pinning technique, which I will show you later, which is you take the long sheath, you take the aspiration catheter, you take your microcatheter, and then you place a stent retriever, and then you remove the microcatheter, sorry, and you advance blindly because you don't have the length on the stent retriever wire, but you advance blindly then the 3 Max and go all the way to the clot and do a combined technique. So again, both things can be done. I find it easier for somebody who starts on these occlusions to do it quadriaxially. It's safer. If you have experience, then it's no problem to do the exchange technique. You just have to be careful to not, remove your stent retriever as you are exchanging the long microcatheter to the small 3 French aspiration catheter. Again, so we've done this here. You can see we have gone to the clot. We have retracted a little bit the stent retriever, so we actually wedge this whole system. Then what we do is we retrieve the system towards the large aspiration catheter in the one. One point that's important is, as you will see also in the next slides, when you start with aspiration. The point is that I start with my aspiration in the moment I reach the clot with a 3 Max here, for example. I haven't started the aspiration on the proximal catheter yet. And then when I retrieve the whole system, stent retriever, clot, and tip of the small aspiration catheter, and I reach with the clot the large aspiration catheter, then I start aspirating also there. The point is that you may lose some fragments the moment that you retrieve the system, the unit with a clot in the large aspiration catheter. And that's why you then have to also have additional aspiration there. And this was the result in this case. You can see we have, after 1 pass, recanalization of the vessel. We have some small spasm here, but overall good reperfusion. And then you can see the day 1 DWI here, where we have some DWI lesions, primarily on the cortex, but this whole, large lesion that we saw initially on perfusion is not there. So we definitely could save some brain, and the discharge NHSS here was 3. Here is a nice comparison, I think, about what could have died if we didn't do anything from brain, and what you see on the DWI as ischemic lesion or as infarction, and also to the point about automated software. I think we have to have new software that are dedicated to MeVO, because at the moment what we see there is not 100% the truth. I find in my experience. So this brings us to, the techniques that we are using for MeVOs and for DVOs. Before, I go to my cookbook and show you my recipes, let's start with what data we have at the moment regarding MeVOs. As you can see here, this was a nice paper showing the blind exchange mini pinning technique, which we touched a little bit on before. So you have the clot, you go there with your microcatheter, you place a stent retriever, and then you remove the microcatheter out of the patient, and you introduce a small aspiration catheter. Usually it's the 3MAX right now. And I really hope that the other companies are going to produce also materials. I hear that Sophia 4 is coming at some point, which I really would like to have and use. I've talked to Stryker for a lot of years that we need a cut 3 at some point or a cut 4 because we will be going distal in the future. And I think it's important to have also dedicated materials for those occlusions. Of course, right now we use the 3MAX. But I think we can learn from, also LVO treatment and also from the experience that we have for DVOs and produce better materials dedicated for MeVOs and for DVOs. Okay, back to the paper. You can see here that we have this case this is the setup that you have, but we also want some data on, the results that we find. And as you can see here, on this paper, compared to stent retriever only, you can see that the combined technique has better first pass recanalization and also better end of procedure recanalization. Again, I think the numbers are not really important because those are smaller trials with not thousands of patients, but we definitely see a difference there. And this is another paper showing similar results as compared to aspiration only. So again, here you can see the blind exchange mini pinning technique, and on the other side, the standard cohort, which included also patients with aspiration. And also here you can see there's a difference on first pass Tiki 2B or higher, 80% to 56%. But again, those were smaller trials. What I really found interesting was this really nice systematic review that appeared a couple of weeks ago. And you can see there were 2,500 thrombectomies included, mostly on M2s, but also there were M3s in there, and also the anterior occlusions. What they did is they divided the first line technique to aspiration only, stent retriever only, and the combination of both for distal occlusions. And as you can see here, the success of recanalization was higher in the combined group with 83 to 75. I will not, count every percentage there. That's the beauty of YouTube. You can stop and freeze the image, and you can study the whole numbers there. But these are some of the numbers that I found interesting. That overall recanalization rate was 77 for distal or medium vessel occlusions. If you're doing a combined approach, you have 83%, which was higher compared to the other groups. Let's talk a little bit about the feared complication if you're going distal, bleedings, where you can see that subarachnoidal hemorrhages are not so infrequent, especially when you're going in the combined group. You see 12% compared to 9 and compared to 2. So you would think, okay, this is really high. But one thing that the authors discussed, and I also find this important, in my experience, sometimes you even have up to 30% of the small extravasations of contrast or of small SAHs that you don't see the next day. So are these really important? If you say the symptomatic hemorrhages are important, you can see that it's 80% for the aspiration group, and it's 4 and 1% for the stent retriever and the combined group. So actually, if you take the symptomatic bleedings, it's better to do the combined technique, right? And this is also shown in the functional independence, where you can see that the group that is performing better here is the combined group with 61% compared to 46% for the aspiration group. Again, this is no randomized trial comparison. This is a systematic review from multiple, retrospective trials and papers. But it still gives you a direction, and I think we will be having more data from the randomized trial that are coming. We do the DISTAL trial. Canada, there is ESCAPE MeVO. The DISTALs in America, and also in France, we have the DISCOUNT trial. So again, I think in like 3 to 5 years, we will have available data to maybe answer also this question for distal occlusions. But of course, you need more details, and that's probably why you have tuned in this channel and are seeing this video. So let's talk about NM2 occlusion. We had this case a couple of moments ago. Typical mid-M2 occlusion, non-dominant AST, vessel. Sorry for my German word there. And we go on and place the stent retriever here, right? As I've shown you in my case, I was also a little bit distally to that position, but I understand if some people, want to stay before the curve in the insula and place the stent retriever there. What I've heard in a lot of talks the last months is that, yeah, you can take like a big aspiration catheter, go all the way to them to aspirate there, and I've seen people doing that, but what the point that I see if you're doing that is that you're taking a big aspiration catheter and you're putting it in a vessel that's already dilated, and this is already maybe small for your aspiration catheter, right? So because it's already dilated, you don't really have that extra elasticity for the vessel to accommodate the big aspiration catheter. And what can happen actually is exactly what I've marked here, that you have some, further extension of the vessel, and that can even produce a bleeding, right? You can even dissect the wall there with a big aspiration catheter, and then when you aspirate, you actually will have a big bleeding after that. So for me, this is something that can be described as a problem, maybe. If you oversize the aspiration catheter, you can dissect them too, and then people are going to be having hemorrhages, which you definitely not want, because this can also be then a symptomatic hemorrhage. So again, for me, this is problem number one. If we're talking M2, if we're going a bit more distally to the M3s, then I can see also other problems. This is a typical case, M3 occlusion. You can see there mid M3 after the insular curve. Let's describe a little bit the anatomy there. Again, you can see that with the new catheters, you can go all the way to the M4 with your microcatheter. In this case, it was a headway duo long. And what we've done for the distal trial, for example, is that we have simplified how we describe the vessels. So for us, the horizontal part is M1, the vertical part is in M2, then you go to the next horizontal part, M3, and then the last here, or the next segment, is the M4. And then you can see we placed the stent retriever here from the M4 to the M3. Again, the clot was here, where my aspiration catheter now is. And you can see the big aspiration catheter is in the M1. This is the lateral view of the same thing. This is my setup for example NM3. So I take a long sheath in the carotid. I take then a big 60 something or 70 something aspiration catheter in the M1. I take a smaller aspiration catheter in the M3. And then I take the long microcatheter to be able to put my stent retriever in there, my 3 millimeter, 2.5 millimeter stent retriever in there. If you want to use the quadriaxial approach, you should take the small 153 3 max, because if you're taking the 160, then you don't have enough length for your microcatheter to work there. Again, regarding the positioning of the stent retriever, I use the small stent retrievers from the M3, from the proximal M4 to the M3, or from the M3 to the M2 for M2 occlusions. And then I go all the way to the clot with a small aspiration catheter, and I leave the big aspiration catheter in the M1. So this is how it looked like on the sketch here. You see the clot, you see the stent retriever there. This is the microcatheter that we're gonna remove to introduce the small aspiration catheter, or if you take the short 3MAX, then you can use it and go all the way to the clot and then remove the microcatheter to be able to have more aspiration volume within the 3MAX. The problem that I see if you don't use an intermediate to the intermediate aspiration catheter is that when you pull the whole system, you actually see here what can happen. So this is a feared complication. You can straighten the whole system, and then you have this rupture of small perforators. And one thing that we try to do, and how we try to overcome this problem, this straightening of the M2 and this perforator rupture, is that we actually try to minimize the forces applied to the curves. So again, the problem if you have a stable point here and then you pull all the way from the M3 is that you're doing what Archimedes described, that you have a stable position, a fulcrum, and then a lever long enough, and then you can actually move the wart if you have this constellation. And we don't want to move the whole vasculature there. We just want to move the clots. So what we do is that we try to produce more stable points, and then we minimize the forces, as you can see here. So we then retract the stent retriever within the tip of the aspiration catheter there, and then we retract the whole unit, stent retriever, clot, and small aspiration catheter towards the big aspiration catheter. And the tips of the aspiration catheters are working like stable points for our forces to be applied. So this is problem number 2. What's problem number 3 actually is that if you aspirate early enough, as you can see here on the slide, then you will produce a vessel collapse, and then you're actually retrieving your system in a collapsed system, and that's not really a good idea, because then I think you will have even more vessel damage and bleedings. So for me, this would be problem number 3. Sorry, it's number 2 for the M3s, but we also had the discussion about the M2s. So retrieving a collapsed system is not a good idea. And it's not like this is only theoretical. If you see this paper, they nicely showed here how you can collapse even a stented segment. So this was a case that had a flow diverter. The flow diverter had a thrombosis, and then they tried to aspirate the clot from within the flow diverter with a 3MAX. And as you can see here, this is what happens in the system as it collapses, right? So this can actually happen even in a system that's stented. This is the proximal aspiration with I think it was a 5 French aspiration catheter, and you can see that even then you have a collapse here of the distal M1. So again, this can happen. They also showed this in the in vitro models, and you can see how the vessels actually collapse. They also showed this in OCT images here, that this can happen. So this is why we try to time our aspiration correctly. So first we put the 3MAX here at the face of the clot and then start aspirating. And then after we have, our wedging position with the stent retriever, the clot, and the small aspiration catheter, and we retrieve this to the tip of the aspiration catheter, then we start with the aspiration catheter in the M1 segment. And then, not so infrequent, you have this result here that you have an open vessel after one pass. So again, if I can summarize, our tips and tricks for distal occlusions, Still, we try to place the centrifugal distally to the clot. So it's the same as we did for the LVOs with our SAFE technique. And actually, I'm describing it to our fellows as the SAFE to SOLUMBRA technique, because you actually, you retrieve the whole system to a large aspiration catheter. So you can actually think that it's, combined SAFE to SOLUMBRA. What we do for M2 occlusions is what we usually combine the centrifugal with a 4 or 5 French aspiration catheter. So again, not many options there, the 4 Max or the Sophia 5, the CAT 5. Yeah, again, we are hoping for more devices in the near future that are dedicated for MeVOs. And if you're going even more distally to the A3, to the M3, then you will we use smaller aspiration catheters, like, for example, the 3 Max. This is an important note, I think, because, actually, if you see how, the devices are sized, one is not sure if this is possible, but we use the headway duo with most 3mm centrifugers. And also, if you don't do blind mini pinning, then you have to use the shorter 3 French aspiration catheter, and this is available now in Europe. So you can order the 153 3 Max and then be able to do this approach. For me, it's not needed. You can also do the blind mini pinning exchange, but if you just start with DVOs, I think it's easier if you work quadriaxially, and then you don't have to do the blind exchange. But again, as with everything, I'm open to suggestions if you have a better idea about doing this. And what we try to do is to create multiple joints, so we then reduce the straightening of the vessels and the drag and the possibility of the perforator rupture. Okay, so I think we have talked enough about distal occlusions. This is another interesting case in the posterior circulation. So we have talked enough about the anterior circulation and the MCA. Let's see a case of posterior circulation occlusion. This was an older patient, 72 years old, 8 hours after symptom onset. And comes with a really mild or low NHSS, mild symptomatic with hemianopia and leg paralysis. But again, for this patient, it was clearly disabling, and we were able to discuss this with him, and he was open to treatment. So what you see here on the native CT is no demarcation. You don't really see extensive ischemic signs. There is no hyperdensity on the P1 segment or the P2 segments. And then what we see on CDA is an occlusion. So you can see the PCA occlusion on the left side here. And the form of this occlusion is also interesting because it's kind of this tapered sign, right? Which is associated with ICAT, so intracranial atherosclerotic disease. So again, you can have your CADs here. You can see there is a mismatch on the left side, and on the left PCA. If you check the single cards, you can also see that there is a lot of area that's affected from this occlusion on the left thalamus and also on the left PCA territory. But there is a mild reducing of the cerebral blood volume, and also the CBF, the flow is also not highly affected. So to summarize, we have a case with an older patient, 8 hours from symptom onset, 3 points on the NHSS scale, no early signs on CT, left P1 occlusion, and a mismatch on the PCA territory. So the question would be again, what would you do? Would you go for treatment and do MT? So if you take these 3 options. The first one, we go to angio and perform MT, vessel is occluded. So this is a typical plumber's approach, right? I see an occluded vessel, I want to open it. Second one would be, well, we don't do anything for this. This is too dangerous, and the patient is not severely affected, so we don't really need to treat with a catheter. And then what I would advise to do is to randomize in a trial. These are now the angio images after your randomization if the patient lands on the EVT arm, right? So you can see here the angiogram of the left subclavian artery. Well, the proximal part of the vertebral is not really inviting, but then we switch to the right side to check if we are able to go in there with our guide catheter. Although it doesn't seem so, problematic, I wasn't able to actually reach the vertebral and have a good flow from the femoral side. So what I decided in this case is to go radial. And I think it's also a nice case because then you can see that we have now a lot of options. If we don't want to do this from the femoral side, we can go from radial and have the tools for this treatment. I was able to reach the vertebral here, and then you can see the occlusion on the DSA. Left side, P1, P2 segment, and you can also nicely hear this tapered sign, right? So you're probably thinking right now, it could be ICAD related, right? It's not demarcated, the perfusion shows minimal core, but a big mismatch. This could be a atherosclerosis related occlusion. And the question would be, okay, what are you doing? Are you still going and aspirating? So if I could ask you what's cooking, doc, answer number one would be direct aspiration with a 5 French aspiration catheter. 2 would be 3 millimeter centrifuger, a small aspiration catheter, and save it. Again, if you want to check our tutorial on our save technique, you can click on the description below. It's just, provocative answer number 3. Friday afternoon, next patient is waiting, and this is getting dangerous for the patient. I don't think that's really an option, but it was actually a Friday afternoon case, and the next patient was waiting in front of our angio. So we would like to do a quick treatment, as always. It's a stroke. But as you will see, it wasn't as we planned. So this is the case with a stent retriever in place. And you can nicely see, I think, where the main clot or plaque was. And then you go on and retrieve this. And this is the result. So actually, for me, at this point, I was pretty sure it's ICAD related. But the question then is, okay, can you leave it like that and it stays like that? Or do you have to do something else? And we have nowadays options with, small, flexible microstents that you can place there. But what I started doing a couple of years ago in those cases where I wasn't sure of the first pass is to actually wait a little bit. And after some minutes to do a repeated run, so some 5 minutes later, this is what we have. So hasn't changed a lot, right? You still see the occlusion there, the tapered sign, and our plan after something like this is we do a flat panel CT, we exclude a hemorrhage, and then we load with Agrostat, which we are allowed to use here in Basel. So it's a GP2B3A inhibitor, and we use the normal cardiology dose. So if you're from Europe, you probably know the lower dose that we use for neuro interventions, and we actually started using now the cardio dose. So this is the dose you will find if you Google Agrostat and dosing. There is an online calculator, and it shows you the cardio dose actually. and not the lower dose that most neurointerventionalists used in Europe. Then we also load with 500 milligram of IV aspirin. And then what we use mainly for these occlusions or for this stenosis is a dedicated neuro PTA balloon. It's called a NeuroSpeed. And I really find this is flexible, and you can use it safely for those distal plaques. And then you go through this balloon and stand with a 017 microstent. Again, no preference there. You can use the Credo, Pegasus, Atlas. They're all good microstents. But I'm really excited to see this coated microstents that are coming up, and that maybe are even more safer for these cases where you have to acutely load with inhibitors, GP inhibitors, or with aspirin. And then what we do in the follow-up is that we do a CT or MRI on the next day. If we don't see extensive signs of infarction, we stop with agrostat and we load with clopidogrel. So we then have our dual antiplatelet treatment. So this was the result after stenting, PDA and stenting of this case. You can see there is a flow distally to the stent. And on day 1, we had DWI showing some DWI lesions, but not to the extent of the perfusion deficit that we saw. And the whole PCA territory is not infarcted as could be if this vessel was still occluded. The whole thalamus is not infarcted. And on time of flight angiography, you can see that there is still filling distally to the stents here. So we have a nice result even on day 1. And on 3 months follow-up, this case, this patient is now asymptomatic, has an HSS of 0, and both stents are open. So again, a nice case, even a complicated one with PTA and stenting, but one that we could be doing more and more in the future. And I think this is another topic that at some point we have to discuss, that ICAT-related LVO or even MeVOs are a future trial or a point that should be in our focus in the next few years. So to conclude this presentation, to conclude this YouTube video, I think, and we think in Basel, that mechanical thrombectomy for MeVOs or DVOs is feasible. We have discussed a lot about the techniques that we are using and the devices that we are using, and the combination of how you would use it. I think there is, as always, the devil is in the detail, and it's important to see and understand those details, to not produce complications and help the patients with a first pass effect. And that's why we in Basel choose a combined approach, and we use stent retrievers and aspiration catheters combined for the treatment even of MeVOs and DVOs, as we used to do in the past for LVOs with a safe technique. If you like this video, feel free to subscribe to our channel, and we will be producing also other videos about PCA and anterior occlusions in the next few months. Of course, we also have videos and tutorials on LVOs. So again, feel free to subscribe and to watch the latest videos in the next few months. And of course, I would like to thank my whole team here in Basel for their support and for their magnificent work. If you're interested more about our department and about positions that or possibilities that are available here in Basel, feel free to text me through social media or mail me at my USB email. Thank you, and have a great day. Bye-bye.